Welcome to the American College of Surgeons Bulletin Brief from the Frontline Surgeons' Voices. With me today is our immediate past executive director, someone to whom we all owe a huge debt of gratitude, not just surgeons, but patients throughout the world, for tremendous strides forward, to which Dr. Hoyt has brought us, unparalleled, unprecedented heights for quality care, not only in the USA and North America, but throughout the globe. So it's a pleasure to see my friend, Dr. David Hoyt.
Good morning, Steve. How are you?
Good, great to see you. I know it's the end of a tremendous tenure, many things accomplished during that time. But for the purpose of today's interview, I want to focus on two particular major milestones that have begun under your watch: the centenary anniversaries of both the Committee on Trauma and the Commission on Cancer. So perhaps I could turn it over to you to talk about those organizations, the milestones along the way that they have, and what they mean to the college, and anything else you'd like to say.
Great. Well, thanks for having me today. And you know, in 2013, we celebrated the 100th anniversary of the college, and celebrating the 100th anniversary of the Commission on Cancer and the Committee on Trauma is sort of like chapter 1 and chapter 2 in that book. And it's in particular because what the foundations of the college, which were to focus on developing standards for surgical care and education of surgeons toward those standards, really have been brought to life over the last 100 years in the cancer programs and then the trauma programs. And they do a lot of other things, but at their heart are those two things. And there's a particular reason that the two have shared that. For cancer first, it was the fact that at a time when we were introducing other modalities for treatment of cancer, at that time, it was radiation therapy, radium. There was not clarity as to whether surgical care or radiation therapy should be used. And so what the college did in 1931 is it created a set of standards for operating a cancer clinic. And it's the same principle that we use 100 years later to establish standards for, in your case, Dr. Wexner, colorectal surgery. But they realized that there needed to be a set of principles that good cancer care would involve. And they included things like having a multidisciplinary discussion. We think of that as something that we're advocating for today, but in fact, that was articulated 100 years ago. They identified that certain cancers should be seen in one of these cancer clinics because they were complicated enough and there was enough alternative forms of therapy that a patient would best benefit by having that visit and then that discussion. So the original standards in 1931 really probably, other than the standards that were developed for hospitals that became the Joint Commission, those standards in 1931 are probably the original programmatic standards of all programs. Now, on the trauma side, it was a very similar problem. In the early 20s, there was a lot of vehicular trauma. We were becoming an industrialized society. There were increased industrial-related injuries, and there was high variability in the care of patients with something as simple as a femur fracture. And so Dr. Scudder and some of the founders basically went to the regents and said, just like they had with cancer, we need to have a uniform approach. We need to create standards for how we care for certain conditions. And that was the origin of the Committee on Trauma. Now, the Commission on Cancer today is an organization of 60 different organizations. So the original efforts in cancer were under the name of the Committee on the Treatment of Malignant Diseases. That was the original name. That became then renamed as the Committee on Cancer. And then that became the Commission on Cancer. So it's gone through several versions over the 100 years. But today's version is probably in particular important because of the representation of so many other organizations and the participation in the care of these patients. So literally, medical oncology, radiation oncology, all of those people play a part in developing the standards that we then verify through the verification program.
Thanks very much for that history. That's a very good outline of where we started, our roots. Now, each of those programs has had many accomplishments over the years. I mean, certainly during my tenure on the regents, we had Stop the Bleed for trauma. We had regent statement on firearms. And certainly within the cancer program, as you very kindly mentioned, we began the National Accreditation Program for Rectal Cancer. A lot's happened, obviously, and perhaps you could outline some of the major milestones of each of the programs during the last century.
Yeah, well, both of them, again, just as their origins are very similar, their model and their programs have developed in a similar pathway. And it really has become the foundation for what we call our quality model. So if you were to say, what's the quality model for the American College of Surgeons? It's a four-part model. And we articulated this about 12 years ago when we were trying to refocus the energies of the college on quality in the eyes of the public and the payers and government, et cetera. And the four steps are to, one, write standards. Both trauma and cancer have done that. They have modern versions. Cancer has increased the standards by expecting certain details of an operation to be followed. That's a new part of that program in terms of the standards. The trauma program has just released their new version of the standards, which started in 1976. So step one is to sit down with a group, come to consensus on what the standards should be for care, and then write them down. And we now across the college have 9 different domains that those standards fall into. And again, those were based historically on what was developed in cancer and trauma. The second step is to then have a hospital go through the process of adhering to the standards. So they build out the infrastructure, they buy the equipment, they get the staffing relationships that they need to deliver the high-end multidisciplinary care. They create checklists. They create all the infrastructure that's needed to create a seamless experience for a patient in either trauma or cancer. And that's a concept that today has been modernized by Michael Porter in the concept of an integrated practice unit. So when you create, based on standards, a delivery system that is designed to be multidisciplinary and serve the patient all the way, you're creating what is considered the modern delivery system for healthcare. And again, cancer and trauma have been doing it for decades. So that's step two. Step three, and again, both of these programs have done this, is to commit to improvement from the beginning by measuring performance against those standards. Thus, you need a database. The database has to collect clinical information for cancer, its outcomes, its adherence to certain process aspects, its long-term outcomes in terms of mortality rates. For trauma, it's the same thing. It's adherence to certain standards in timeliness of care. It's adherence to avoidance of issues like complications such as DVT or pneumonia, and then ultimately mortality as well. So that's step three. Measure the performance of the system and look at the data and use that data, benchmark it nationally so you can compare yourself to others, and then use it to identify areas to improve. And then the fourth step, both of them have done, and they're really unique to the American College of Surgeons, is to offer a verification program, which, if you will, uses peers to judge whether the hospital is performing against the cancer or trauma standards in the way in which they're supposed to. And by using peers, we then remain objective. We ask hospitals to go through this every 3 years. And probably the most important thing we do with that is assure the public that those hospitals, whether it's a cancer center or a trauma center, are delivering the care that we say that they're delivering. So when they put that plaque on their wall that says they're a certified trauma center or cancer center, the public knows that those standards are being met. So that four-part model is what we've promoted, and I think it's been very, very effective. And it really, again, links back to the legacy of these two programs. Now, there are a lot of other programs that each has developed, and cancer has done all kinds of public outreach things. They have started to become more granular with offering specific programs we mentioned rectal cancer, breast cancer, more recently, high-end GI cancer, so pancreatic, esophageal, lung cancer, et cetera, et cetera. And those programs are going to really fill the gamut of all the complexity of care that cancer care today needs. Trauma, similarly, has moved into other areas, in particular in prevention. So one of the requirements of a trauma center is that they not just be there for the injured patient, but that they anticipate injury and try and prevent it. So things like firearm safety, helmets for kids riding bicycles, advocating for seat belts, the proper use of seat belts during pregnancy, and more recently, the Stop the Bleed campaign has really become incredibly innovative. And in that, it's become sort of the CPR for bleeding. So if somebody is injured, bystanders have been taught and are continuing to be taught how to curtail bleeding until the patient gets to definitive care in a trauma center. So all those things become the domains of these programs. And as a result, they've become two of the largest programs in the college. Each has over 50 employees working full-time on behalf of cancer or trauma.
Also impacting a huge number of hospitals and therefore patients throughout the country. From memory, there's about 1,500 COC accredited hospitals. What's the number for trauma?
It's right around 700. The other one that's actually surpassed trauma in the last year is bariatric surgery. Again, a high-end program that needs multidisciplinary care, needs that concept of a integrated delivery system, integrated practice unit, and there's about 800 of those. So between those three programs, we have over 3,000 hospitals participating.
And I know we're certainly not stopping there with the addition, as you mentioned, of the high complexity GI surgery. Also, of course, the Red Book and the Gold Book. And maybe you could tell us a little bit about the integration of some of the overall quality initiatives, which leads to those most recent projects, Red Book, Gold Book.
The quality verification program or Red Book really came out of all these conversations, Steve. So when I came to the college as executive director, I had experienced what I saw happen with trauma care with organized college programs. And although I was very involved in a traditional academic program and doing research, et cetera, the opportunity to really see what these structural elements by creating organized programs do to care was just very, very appealing. And so one of the focuses that I've tried to do is to expand these both in cancer and trauma, but also in other areas. So Dr. CoC and I, about 7 years ago or so, were sitting down and saying, what did we learn from each of the programs, cancer, trauma, bariatrics, et cetera. And what we realized is that after all was said and done, there were some very, very common principles that are behind any quality program for any surgical condition. And so that's what led us to write the so-called Red Book and organize the standards into 9 different domains, which all the programs now conform to. And then it becomes a very specific way to approach a hospital, help them organize their resources to perform at a high level of quality. And then they can tailor to what they are particularly good in, whether it's cancer or bariatrics or trauma, et cetera. So the Red Book, the quality verification program going forward will be the backbone of these programs. And we hope that a hospital will participate in that and then also participate in these other programs. And a lot of the work in the next couple of years will be to simplify that process, bring those programs together, bundle them, lower the costs, et cetera, so the barriers to entry for hospitals will be lowered. But the principles are the same. And there's ample data to show that when you go through that process at a hospital, you improve care, you reduce mortality, you reduce complications, and you save money. So for all those reasons, it makes sense to do it.
Yeah, and I think in addition to saving money, we're certainly saving lives with the trauma program, having the various levels of trauma center and Stop the Bleed program. And ideally, as you also mentioned with cancer, as we move from process measures to performance measures to outcomes measures, hopefully also saving lives as well. So what do you envision as where the college will go now that you've left your role as executive director? Where will we be going with the quality programs, and perhaps specifically cancer or trauma? What are the next goals?
Well, I think, that remains to be seen with the folks that take these over, but the validity of the programs is very, very strong. I think people that have participated in them understand the value of them. Getting the payers to recognize that, getting the public to recognize that so that there's a degree of expectation will be very, very important. And part of that's going to be tied to creating an easier and a more sort of streamlined process for hospitals to participate. I think that's possible. I think we have spent a lot of time in the last 10 years trying to integrate these programs into more and more specific areas of disease where there's complexity. So, 25 years ago, a pancreatectomy was a pancreatectomy. Now those are highly organized centers in hepatectomy and esophagectomy. We know the conditions that really need this kind of detailed integrated practice unit. We've focused on building those. And now what we need to do is make this easier for hospitals to develop the overall infrastructure. I think from the databases, the biggest innovation is going to be able to extract the data that is needed to do the metrics and create performance metrics for hospitals by pulling it directly out of the EMR. And that's proven to be much more difficult than we anticipated. It is possible. I think it will be seen in the foreseeable future, but there have been a lot of barriers to that. And so that's another challenge to look forward to. What that will do is free up a lot of FTEs from collecting data to doing quality improvement, which is good for everybody.
Yeah, absolutely. One of the things that has certainly been front and center in many, many conversations are healthcare disparities and bringing these outcomes to everybody, regardless of where they are. Are there initiatives in that specific direction? You said make it easier for the hospitals, make it simpler for the hospitals, and you also spoke about cost effectiveness. But any specifics to ensure that a patient in place A in the US and place B and place C, that they're all going to get the same care if their program subscribed to the MBS QIP or TQIP or COC?
Well, as you know, Steve, our motto is to serve all with skill, and it was fidelity, and we've changed that recently to trust. But to serve all, it has been an aspirational goal. But the college created that goal 100 years ago, and they really need to be praised for that aspirational goal, because they were the first to do that in America. They were the first to say that our responsibility is to provide care for all. Now, the problem has been, particularly recently, the cost of that. And so what we've got to do to expand the ability to serve all patients is help to lower costs. And so we've got a very specific program that we've been looking at that, and we think we have ways to share with hospitals and surgeons so that they can be more efficient in their use of resources, and with that free up some resources to serve all. There are many, many hospitals, there are many programs that do that. Quite frankly, the one program that does that now is trauma. When you are injured in a city or in a rural area and you are part of an activation of the trauma system, the system is payer blind to you and you get care automatically, irrespective of your means to pay. Now, later on in the care rehabilitation, we've got some work to do on that. But we have an example in the United States of a system that truly serves all. And we need to now build that and scale that to other types of diseases.
Yeah, so spreading to other types of diseases is important, and as you mentioned, breast and more recently rectal cancer and complex GI procedures. The other way of spreading it to more people is, of course, international. And as we've gone through surveys, site visits during COVID, we've learned to do it very well, as you and I are doing it today, remotely in different locations, 2,500 miles apart today. So, what do you envision for the international reach of some of these programs now that we can look into their institutions from Chicago?
Yeah, and I think that's a very, very important point because through COVID, that's probably one of the silver linings is that we really learned how to do a lot of this verification process remotely, which saves a tremendous amount of money, travel costs, et cetera. And that will open up the international market. The biggest challenge in the international area is that they have different resources relative to the United States. And so we cannot create programs that require resources that are beyond their reach. And so very well developed countries have no problem doing that. The less developed countries, we can help them move in the direction toward those standards. And we've got examples of that in each case. And the rest of it is really just scope. It's where the college wants to go. There's no question. There's desire, there's interest. People have great respect for the college's programs around the world. And it's just a question of growing into that over the next years as we decide to do that.
Well, one of the reasons for the respect for the program is what you've done over 12 years. Whatever respect there was 12 years ago, that's that much more now because of the credibility and the value of the programs. The word trust is not just from patients, but it's from our colleagues around the world who trust what we do, and they know that we're striving for optimal outcomes and we're doing it in an evidence-based fashion.
Well, I think, see, the other advantage, and I appreciate your comments, but it's also amazing what we can learn from others around the world too. And we absolutely have the best resources and oftentimes the best way to do things in the United States. But we need to keep our eyes wide open because there are incredible innovations and incredible delivery models around the world that we can learn from and adapt in our own way.
Yeah, no, absolutely an excellent point. It is learning, it is collaboration, it's sharing and adapting best practices. Again, with the challenge that resources may be different and resources are different in different places, and you've got to tailor the offering to ensure that it's implementable and sustainable, which is another conversation. But it's great to celebrate these centenaries. Which programs, by the way, are next on the docket for centenary anniversaries from the college?
Yeah, that's a good question. Bariatrics in children started about the same time formally within the college, but trauma started in about 1987, cancer technically in 1931. And there really was not a lot of activity in the 90s and early 2000s. So I would say probably we've got another 80 or 90 years for another celebration. I think you and I may not be there.
It is highly probable, sadly, that we won't. But it's great that we're here for these two. And it's great that you are leading us to them and celebrating the centenary. So thanks again for your time today, and any additional comments, please voice them, and then we'll close.
I think the college should be very, very proud of these programs and what we've done with them. And it really is, in my mind, our responsibility, but also we should feel very proud of what we offer to patients through these programs.
Absolutely. Second that motion. So thanks, Dave. Stay well, stay healthy. Appreciate it. Happy and healthy New Year.